And why don't we go ahead and get started? I'll do just a very brief intro and we'll open it up. Um, so just as a reminder, we are all here to talk about primary care in the greater Seattle area. Huge appreciation and thanks to our panelists who are joining us today. We are very excited that you're taking time out of your schedule to share with our residents a bit about your practice. We have R2s here who are interested in primary care and interested in learning more about the different practice models that are out there. And so what we're going to do is really just open this up for questions. I will introduce myself. I'm sorry. My name is Gabby Berger. I'm a general internist and primary care doc here at the UW. I have my practice at the Roosevelt Clinic, General Internal Medicine. And I'm one of the assistant program directors for the residency program. And I'm really here today as a moderator. So what I would like to do is actually just have each of the panelists, maybe I will sort of call people out if it's okay, and I'll save Sheila for last. I'll call people out to introduce yourself and your practice and tell us anything that you feel we should know. And then I'm gonna just open it up for questions from our residents, if that's okay. And residents, please feel free to unmute or send me a direct message if you'd like me to share a question on your behalf. Okay, great. Excellent. Okay, so we have a number of panelists joining us today. Emily, you are first in my lineup. Would you mind introducing yourself and sharing a bit about your practice?
Of course, I'm happy to be here. My name's Emily Savage, up at the Everett Clinic, just north of y'all, where it's quite lovely. I am a general internal medicine doc who's been doing different versions of primary care up here in Everett since 2006, other regions of the country prior to that. And up at the Everett Clinic, we currently have 3 different ways an internist can be a primary care doc, including general primary care, all ages of adults. I currently would call myself more of a geriatrics PCP, even a Geri-PAL PCP. I'm part of a complex care program that has some similarities to IORA. I saw Cheryl nodding her head. So we offer a couple different models of care depending on the complexity and nature of different patient populations. So I can't wait to talk to you more if you guys have questions.
Thank you so much, Emily. Cheryl, can I ask you to introduce IORA?
Yeah, great to be here. My name is Cheryl Jacobs. I'm also an internal medicine doc who graduated from the UW primary care program a long time ago. And I've been at IORA for about coming up on 6 years. We have 6 clinics in the region. I'm furthest north at the Shoreline Clinic, and we go as far south as Puyallup. We're a national company in multiple other markets, but also really a value-based primary care for seniors. And we're really relationship-based and team-based, meaning we work with a broad team. So the other folks in my team, I have health coaches that I work with directly, and they're in the room with us. They help coordinate care for patients. They're sort of their first direct contact and do a large variety of activities for patients. We have a team nurse, and then we also have integrated behavioral health. And that is super helpful, having a behavioral health specialist as part of our team to manage depression, anxiety. They're there to do direct handoffs as part of visits. And just really help us manage those things as well. I think we also, just as far as probably a little bit different than some of the other systems, is that we're value-based, which I don't know how much you guys know about that, but that really means that we don't, we can see patients as many times or as few times as they need, and that payment structures are not based on how many times we see somebody or for each visit. So we sort of get a pot of money to take care of people, and we do whatever we can or whatever we need to do in order to take care of people's needs in that way. So I think probably one of the differences in that sense, or how that translates, is that Some days I see 2 people, some days I see 8 or 10 people. So there's a variety as to what you're doing. And there's also a large component of population health, which is part of our model. So looking at the panel of patients that we're managing and thinking about that in a more systematic way all the time, as opposed to just in every single visit that you're seeing somebody. So there's sort of work that goes on behind the scenes that doesn't have to be a part of every visit.
Fantastic. Thank you so much, Cheryl. Let's see, I'm going to skip over Sheila. Wendy, can I come to you next?
Sure. My name is Wendy Vandal, and I'm not an MD. I am actually the recruiter for the Department of Corrections. And so I just wanted to talk a little bit about correctional medicine. A lot of people don't think about that as a possibility. But in Washington State, our Department of Corrections owns and operates 12 prison facilities throughout the state. And under the Constitution, anyone who is incarcerated is guaranteed the right to adequate and accessible health care. So all of our prison facilities are equipped with clinics. We do full total patient care. So we have dental, mental health, behavioral health, MAT services, and medical services. We do both an outpatient type service with our incarcerated individuals. And then we have inpatient infirmaries at the facilities, depending on the facilities, different sizes of inpatient units, but they range anywhere from 12 beds to 28 bed infirmaries, as well as we have residential mental health facilities as well. Mostly we do, bread and butter internal medicine or family medicine cases, but they can range all the way up to complicated cases with comorbidities and very complex issues. Our population are often disenfranchised from medical care. And so for many of our patients, this is really the first time that they've addressed their health conditions. We work really hard on preventative and maintenance care. Our incarcerated individuals, when they hit the system, are given our healthcare plan. So we kind of have a managed healthcare plan. The services that we provide are at the taxpayer's expense, but we don't do any billing. So there isn't a billing component and we're not a pay for services type component. Our providers spend a little bit more time on education and making sure that patients are aware of their health conditions and can become advocates for their own health. So we do have a little bit more of that training component when you're seeing patients, making sure that they really comprehend what their diagnoses may be. We also work very closely with outside providers and partnerships in the community. Most of our facilities are located near a regional hospital. So if someone does need to go off-site for services, we're coordinating that and making sure we have a continuity of care in that. Is that good?
Perfect. Thank you so much, Wendy. We appreciate you joining us today.
Thank you.
Leslie.
Hi, everyone. I'm Leslie King. I am a primary care internal medicine doc over at Pacific Medical Centers. I actually did my training at UW and finished up a chief residency at the VA not too long ago. So kind of new to the primary care attending game, but the job search was pretty fresh in my mind. So happy to be here and kind of contribute my insights. So I work at Pacific Medical Centers, which is a group of 9 clinics around the Puget Sound. I'm at the Beacon Hill Clinic, which is that big, beautiful brick building that you see kind of going from I-90 south. And we are basically a set of community clinics, and we have some specialists as well that are within our system. We're a part of the Providence system as a whole, though they're kind of our overarching system as well. So we're also connected to Swedish, which is also part of the Providence system, and other Providence providers. So we're kind of a larger health network in that way. We used to be independent, but as the way is going for a lot of healthcare clinics in the region. Were eventually kind of bought out by Providence, and they provide a lot of our support in that way. We have a very community medicine feel for sure, and each of the clinics, they're kind of our patient population, our kind of, we all have different vibes and different kind of like feel for the patients we take care of, and kind of each clinic has its own unique personality. We are a primarily productivity-based system, so I'm just moving into that now in terms of like payment structure, but we basically, you know, the patients we see, we get paid for them based on their level of complexity, billing, all of this stuff that I feel like in residency is kind of, we're pretty removed from, but becomes more of a reality once you move into full practice. Like I said, we also have a network of specialists within PACMed, but also have access to the Swedish specialists, so whenever we need help with a patient too, they're pretty readily accessible. And again, it kind of has a really nice community feel where, you know, sometimes the surgeon's just down the hall and it's a matter of knocking on his door to ask a question. Here at Beacon Hill, we are kind of smack dab in the middle of the Central District, the International District. So we see a really great diversity of folks from a cultural standpoint. We also see a lot of folks with good socioeconomic diversity as well, because we take a mix of payers, including Medicaid, Medicare, traditional insurance. And then there's a special population we work with, which is actually retired military and their family, which is one of the reasons I was really interested in PACMed coming from the VA. So we are contracted with the U.S. Family Health Plan, which is again a health plan for retired service members and their families. So I miss my vets from the VA all the time, but I still get to work with them somewhat here with folks who are on that insurance plan. So yeah, happy to be here.
Thanks so much, Leslie. Doug, I'm going to come to you next.
Great, thanks for letting me be here. So Doug McMillan, Community Health Center of Snohomish County. I've been here for close to 9 years now, primarily doing outpatient that is, but general internal medicine for federally qualified health center. So we're taking care of almost all underserved population, 80% Medicaid, majority, all the rest, no insurance and Medicare. So we have 7 clinics scattered throughout Snohomish County. Our board is over 50% based on patients, so it really is trying to be for the community. Each of the clinics has a lot of family practice, as well as some pediatricians, internists like myself. Most of the clinics have their own pharmacy, so that we can get patients the medications cheaply, like $7 for insulin per month, things like that. Dental, and we even started physical therapy at our site, which is great. I am a clinical director for the Edmonds site, which is just like a mile north of the county border. But and so I do supervise the other providers here. But like I said, 80% of my time is doing clinical work, doing that. We love the mix of variety of patients that we're seeing here. I really love doing this because as with like when working at the county hospital during residency, I missed that afterward when I was in academic medicine. And so I really love the working with this population here so much and doing it in a way that's financially viable for the organization to sustain and being involved in the community, which is what I really love about working here. And it's been great. And like I said, sticking around for 9 years now.
Thanks so much, Doug. So for our residents, I'm just so excited at the diversity of folks who are here to share their perspectives today and to talk a little bit about their practices. And as a reminder, you have access to folks who are doing academic primary care sort of all the time. So really want to take this opportunity to focus on what jobs look like outside of academic medicine. And Sheila, is this a good time for you to join us, or do you feel like you are?
Yeah, no, it's great.
Okay.
So I just will apologize to everybody. I kind of was added last minute, so I'm juggling picking up my little 6-year-old. So if you hear a little voice in the background, we're just going to go with the flow because that's kind of what the last year and a half has taught us, right? So I am a recruiter for Swedish Medical Group, and to piggyback on what the PACMed physician said, we are part of Providence. So we're nonprofit. We'll see everybody regardless of their ability to pay. I think there's a misconception about Swedish that we only take certain patients. That is not true. and again, what that physician said at PacMed, I think primary care is primary care, and then it becomes about like what fills your bucket, and you know what's your personality type, because each clinic definitely has its own personality. So I think it's about making sure that when you're job searching, tell the recruiter like, this is what I'm looking for, to make sure they're not just putting a warm body in a spot. But our primary care clinics, a lot of them have internists as well as pediatricians. Some of our APCs have their own panel. We also have things called, it's like a care model where some of our APCs take 50% their own panel, then 50% they're helping physicians, typically new grads coming out just with refills or patient follow-ups, just to kind of help that transition between residency and having your full panel. Let's see, what else can I tell you? Each of our clinics has a really diverse payer mix. Some clinics, obviously, like let's just say Sandpoint or something like that, the patient population isn't quite socioeconomically or culturally diverse, but we do have other clinics like First Hill or Richmond Beach, where if that's what you're looking for, we definitely have that as well.
Great. Thank you, Sheila, so much.
Yeah.
Okay. All right. I want to just open it up for the residents. What questions do you have? Feel free to unmute. You can direct a question to anyone or to the group. And nothing's off limits. I'm going to get us started with a question that I know is on people's mind and hopefully just break the ice. It's okay to ask anything. And I brainstormed a whole list of things that I wish I had thought of when I was looking for a primary care job. But I want to hear from you all. The first question I'm going to ask, and just go around sort of popcorn order. How big is what's your panel size? Yeah, Emily, how many patients on your panel?
Thank you. So when I did traditional primary care up here, I was on a mostly fee-for-service, productivity-based arrangement in the clinic, and I was a 0.6 with little kiddos, and my panel size was about 1,500 patients, and I would see 18 to 20 patients a day. About 6 years ago, I transitioned to this geriatrics practice, which is in many ways quite similar to the IORA model that Cheryl talked about. We have value-based contracts. I am specifically seeing patients that are identified as more complex, more high needs. I have social workers, pharmacists, extra nurses, care managers, a palliative team, and we all work together. And I now, as of today, have 206 patients on my panel as a 0.6, which is about what I should have. I see about 10 patients a day, sometimes 8 if I do a home visit, and spend a lot of time with my team. We do interdisciplinary rounds, a short half hour every day, a longer one once a week. That's about an hour, where we run through running my panel. We use population health as well, identifying which patients we need to be intensifying our outreach to, which ones have been in the ER again, figuring out how to connect and take care of these patients. So I will say that that's I've stayed at 0.6 my whole time here with family, other obligations, and I'd say it's just as intense, probably more rewarding, definitely not less work having 200 patients. It's kind of like the work fills, for whatever your capacity is, it seems, but it's pretty awesome. I didn't mention, I just will also let you know, the Everett Clinic spans a wide geographic region up here. We got multiple satellites also overlapping with Edmonds, Shoreline, up all the way to Smoky Point, Stanwood. I'll leave it at that and let someone else talk. Thank you.
That's so helpful. Thank you so much. Let's see, Leslie or Doug, can I ask you to jump in next?
Sure, I can jump in. So we adjusted, so we use adjusted panel size, right? So adjusted panel size is this like the idea that comes up where basically patients are adjusted based on their complexity, and all of that comes, a lot of it from coding, these HCC codes that have to do with kind of different medical conditions that up the complexity of patients. But essentially a 1.0 physician is an 1,800 patients adjusted for complexity. I will say that no one in our clinic works 1.0. It's just like, it's a lot to do 5 days a week of back-to-back patients. And so most people are 0.8 or less. I'm 0.8 and I'm one of the highest clinical FTEs in my clinic. There's a couple folks who are 0.9. An average day, we see anywhere from 7 to 9 patients in a half day. And that's a combination between scheduled patients. Sometimes we'll overbook our own patients too, to kind of get them seen for more acute issues. And our appointments, we actually just shifted throughout the PACMed system. They're 30 minutes each. It used to be kind of a mix of 15 and 30-minute visits or 20 and 40-minute visits. We shifted over to this 30-minute module where you get 30 minutes for each patient, which some people have enjoyed, some people have been less favorable to. I've liked it because it kind of all settles out in the end. It feels like some patients will take 40 minutes, other patients will be a quicker visit, but overall, I feel like it's a nice kind of pace for the morning. And yeah, I think that's what I'll say about that.
Great. Doug.
Yeah, and I just pulled up a report to see. It's like, I guess mine's about 1,500 right now. I guess I had to pull it up because I don't keep track of it. It's nothing we think about or worry about on a regular basis. I guess it's more a matter of how that the patient per day and things along those lines, and more impacts on a regular thing. Be different if you're when we move to more of a model of taking care of the entire population that is listed under you, and more of like how Iora's model is, then you have to worry about that more than at least our current setup is. But yeah, so I mean, ours is all set up as 20-minute appointments for everything, regardless of it does, unless there's procedures that you can do 40. But so yeah, so generally about 3 patients per hour, with knowing there's going to be no shows and such things, with expected to get the 2.6 per hour on average is the expectation that you're seeing on a regular basis.
Great, thank you. And Cheryl, I don't know if Iora is significantly different from what Emily described at Everett Clinic.
Yeah, so we also, so panel size somewhat is dependent on your FTE as well as sort of the RAF scores. I'm full-time, but I'm also a clinical team medical director. And so I have a panel of about 500. I have a team physician who's newly out of geriatrics fellowship who has about 250 patients. And she's a 0.8 FTE. She still has some room to grow. So she probably, I think, will end out somewhere around 3 to 350. And we also, so we have 30 or 60-minute appointments. Some of that is really based on sort of the patient. So we have the flexibility of if somebody needs a translator, or we're having a more complex visit and we have to involve family members for goals of care conversations or whatever it is, we can adjust. So the schedule is very flexible to sort of meet patients' needs as far as how much time we need to manage stuff. We also have sort of 60 minutes, each provider has 60 minutes a day blocked out in order to do tasks and sort of do the care coordination, and you know, conversations with the team happen sort of first thing in the morning. So we have a team huddle every morning. That's the first hour of the day from 8 to 9, where we get to really review the schedule, but then we get to dive into a variety of things. We also follow our folks pretty closely in the hospital. So we don't go to the hospital, but we are sort of managing those transitions in and out of the hospital. And that's one of the things that we talk about in the morning huddle as well. You know, sort of how to smoothly pick up the ball, knowing what's going on. Our nurse is one of the folks who manages that. And then we have an opportunity in the morning to talk about complex people who we're worried about, and sort of brain think as a team what's needed and what are the next steps and how to really leverage the team. So I think one of the coolest things about IORA, and one of the things that you've probably not learned in residency, is how to leverage the support of a real team. And those are sort of new skills, especially like our provider Beth is new out of fellowship and residency, and I think those are new skills. But it actually makes it super fun. So everything isn't just on your shoulders. It's sort of helping navigate stuff with a whole team.
Thanks so much, Cheryl.
Gabby, I have a question. Could the panelists share like what percentage of their panel ends up being Medicaid or Medicare patients?
Yeah, I can finish off with that. So we are a Medicare only practice. We do have some small population of Medicare, Medicaid, sort of D-SNPs who are less than 65. And they tend to be pretty complex, a lot of times with mental health issues and other things like that. So we also take Medicare Advantage, which is value-based programs. And we're also newly part of a program. I don't know if you guys have heard about it. It's called CMMI. It's through Medicare, and it's a direct value-based contract. And it's sort of a trial that's happening with, I can't remember exactly how many practices. I want to say about 10 practices across the country. So it's directly contracting with Medicare.
I can go next because it's also pretty easy too. But so yeah, so federally qualified health centers are sort of designed and set up mostly for working on Medicaid, and so therefore with there's a lot of hoops and different things that people have to manage to coordinate and show that we're doing things correctly. But in compensation, we get a higher reimbursement for Medicaid, and so, like I said, it's around 80% of our population's Medicaid, and the majority of the rest is either uninsured, which we have a sliding fee for, or Medicare. I think we have like 1% is private insurance. Everything else is the others.
Okay, I can go. This is Sheila, still doing the mom thing. So at Swedish, it's really dependent on the clinic and on your FTE. So I guess, sorry, we'll start with the Medicare, Medicaid question first. It's really dependent on the clinic location and just like the patient demographics. But again, you would see a mix of all at Swedish. And then the patient panel size, again, dependent on your FTE. I think a full-time has about 1,800, maybe 16 to 1,800. They see about 16 to 20 patients per day on average. But again, it depends on what the appointment's for, the complexity of it. And we also do a ramp up period for new grads, just because we know shouldn't be death by fire hose the first, experience into your new job. So, but those are excellent questions to ask when you're looking for a job. And I would keep a spreadsheet and keep it all there. So afterwards, after you've done talking to everybody, you can really compare it and find out, what makes more sense for you and your lifestyle.
Thanks, Sheila. Leslie?
Yeah, I unfortunately don't have exact numbers, but I'm happy to get those if that would be helpful in your decision making. I think it's somewhere around 20 to 30%, but again, can confirm that. There aren't any limits though. I know there's certain practices that are like only 10% or only 20% can be Medicare or Medicaid patients. We don't have those limits here. And I think it depends on the panel, but most of the time I think it's around 20 to 30%. And I believe that's about how it is on my panel.
I can go on the Medicare Medicaid question too. Up in the Ever Clinic, like the other docs have alluded to, it depends on your location and in particular which specific practice you join. Across the clinic, historically, we've had just a mix of all payers, some Medicaid, some duals. That's, as Cheryl alluded to, the D-SNPs. These are people who are disabled under the age of 65 and go on both Medicare and Medicaid. And we have a significant portion of those. However, it's I think across the board, it's less than 30% is Medicare or Med Advantage, and less than that is Medicaid. Having said that, depending on like where your interest lies and what kind of practice you want, you have options to be a mix of all adults, all different payers, or more the the value-based contracts where you're primarily caring for Medicare type plans, which does include the dual Medicare, Medicaid, but a very small number of those, which are it just runs the range. So for example, my practice, of course, because I am all value-based contracts, I'm 100% Medicare and different types of Medicare plans, but that's not the case for most of the primary care doctors in the clinic.
Fantastic, thank you all. What other questions? And Wendy, I'm skipping you on this question because I know it doesn't apply in the same way to the corrections population, but we so appreciate you being here, and we'll direct specific questions your way. What other questions do folks have?
Hi, everyone. I'm Becca. This feels like a dumb question, but can some of you speak to sort of the pros and cons of a fee-for-service versus a value-based system? I feel like I can imagine them, but in reality, I don't.
Thank you, Becca. Such a good question. No dumb questions here at all. I just want to acknowledge that this is, for many residents, the first time you have an opportunity to even sort of start thinking about some of these things. So thanks for asking that.
I think that's a fantastic question. Yeah, not a dumb question at all. And I think too, like coming from residency and certainly being at the VA to a fee-for-service like system was a big change. So I think one of the takeaway points is that so basically in a fee-for-service system, you are like paid and your salary is on the basis of the patients that you see. And so this kind of productivity, that was very new to me, but essentially what that means is that your paycheck is just, again, based on the patients that you see on a daily basis and kind of the codes you bill for. It's more complicated than that, but that's kind of the take-home bottom line for it. And so I do think that there can be kind of some of this external pressure of needing to see more patients, right? And if you have a patient who doesn't show up, right, that's kind of lost time for you. That being said, there's various ways of kind of filling that time. And it's so much more complex than just kind of patients you're seeing per hour and things when it comes to job satisfaction, but kind of just on a paycheck related thing, that's where fee-for-service, in the productivity-based system, can be a little bit challenging, especially moving out of residency, for sure. I think that, advantages of it too is that your time is, when you are seeing patients face-to-face, is relatively, it's compensated, right? If you add on a patient, you're getting compensation for that too. It's not just kind of you're forced to squeeze it into a day that's already packed really tight. You do get some compensation for it. There's a problem though in that, as another thing that kind of you have to think about in primary care, right, is you're responsible for taking care of your patients 24/7, 7 days a week. And so that inbox management and that kind of between visit care is oftentimes not really well compensated in a fee-for-service system. And so that's something to kind of think about, is how the clinic that you are applying to and the job, how they set aside time for providers and how that time is provided. And there's all kind of models for how that looks, whether it's just specific panel management time, or, various ways that you can get in that time. But it's a good question to ask when you're kind of thinking about, a different place you're going to work, is how can you get that time to manage your inbox when you're taking care of patients? And most fee-for-service places don't necessarily have something built in for that.
Can I ask a follow-up question, Leslie, since you are in a productivity-based model compared to some other folks here? And that is, do you feel like you have some sense of it? How predictable do you feel like your paychecks are? You don't, that's asking just the predictability piece of it, right? Because I'm guessing that's what's on people's mind when you say that your salary is based on reimbursement from patients that you see. So how, is there a way that you can predict that you're actually going to have some sort of floor in terms of compensation?
Yeah, that's a great question, Gabby. And again, I'm kind of learning about this as we go along, because the other thing to know too is most of you, if you start off in a fee-for-service system, you'll have this ramp up period too, where you'll have this guaranteed salary. And what that means is you're paid regardless of how many patients you see or don't see for a specific period of time, like what they consider to be a fair base salary. And then once you've built your panel up, right, because in order to be seeing patients consistently and to be able to have patients coming back to you, they kind of build that into your ramp up where you need this time to build a panel that comes back to see you so that you can fill those spaces more reliably. So there is a ramp up period. And then in terms of schedule predictability, my colleagues would say, and I'm kind of starting to notice, most of the time it is relatively predictive. COVID totally threw that all for a loop. So this last year has been really challenging in terms of kind of the predictability of that, but it seems to be getting more on track. And there's things that you can do, like in terms of like predicted no-show rate, that kind of stuff, that can help you kind of make it more predictable. Our organization tries to help us out with that because they give us basically like a tracking sheet of basically the RVUs you see, or basically revenue value units, are basically like how many patients you're seeing and how much you're getting paid for it. It shows you month to month how many patients you're seeing, how many RVUs you generated, and kind of gives you a prediction for if you stay on track with this over the course of the year, how much you're going to make or not make. And so people respond to that in various ways, either, if they feel like they need to add clinic days, if they feel like they're way below that, or if they notice like, nope, I'm right on track, I'm on track to make more, that kind of stuff. They can kind of adjust things on the basis of that. I would say that for folks who've been in practice for a while, who have kind of stable panels, it becomes more predictable because you can kind of use these no-show rates and kind of, you get to know the patients too, like people who are, more or less likely to show up. And then you can do things like kind of double booking in that slot to adjust for the schedule, or you can, make adjustments in terms of like where people are within your schedule to make up for that. So that was maybe a little bit of a circuitous explanation, but does that answer the question you're getting at, Gabby?
I'd love to pipe in on the Everett Clinic side, what we do, because much of the primary care practices here are still mostly fee for service. And what has been in place since I started, we're a large group with multiple satellites, and they kind of model out your projected productivity based on your prior year's productivity, and they pay you based on your year's prior productivity at 85% draw. That's just the same every 2 weeks. You get the exact same paycheck every 2 weeks, and then a couple times a year they true it up. It always, and so it feels like you get a bonus a couple times a year, because then they're just kind of writing based on your actual productivity relative to years prior. Now with COVID, of course, our clinic did shut down entirely as far as primary care goes for a couple months. And then they had to, when they were doing all the budget stuff, lower the floor to a 75% draw. And we were able to put in other activities to kind of write people's, it was a long thing, but it ends up being, for the vast majority of PCPs, your paycheck week to week just stays the same, and then you get a reconciliation a couple times a year.
Super helpful. Thank you.
I just want to chime in too. I think another important thing that is kind of the team that supports you in terms of managing that schedule, because that's another thing depending on the clinic. Like, so we're a very like one-to-one provider to MA. So we have our own MA that we work with consistently, who knows our patients just as well as we know them. And so we kind of work together in terms of getting people in, who needs to be seen, where they can be seen. And so kind of having someone to help accomplish those tasks. And that's another system we have in place also for inbox management. Our MAs can be in our inbox helping to manage things. We can send them things their way to help manage that. We've also got good primary care triage nurses as well that really help with that too. But some systems, like, it's kind of on the provider to modify your schedule and move things around. We have a little bit of more support here in terms of assistance, medical assistance to help with that, but it really varies. And so I think that's a good question to ask too, is if you are in this productivity model, how are you going to get support for filling out the schedule and making sure that you do see enough patients?
And I'll just chime in from the complete opposite end of things. So we are salaried. I worked in primary care at Minor and James, which no longer exists, but was a Swedish clinic for eight or 9 years. And did the high productivity, the dance that everybody's talking about. And I think the initial question was about just the difference between those two systems. So I have lived those two systems, and the amount of stress from that system is high. So, you know, you're worrying about a lot of different things for a lot of different reasons. And I would say, being in a value-based care system, I think one of the things that is most profound is that the alignment between how I work and how I get paid is in alignment. So I don't have, there's not a conflict. It didn't feel like a conflict of interest to me. I think that's what it felt like when I was in sort of that like little race that was going on. There wasn't a conflict of interest of me having to like think about my coding and how complex this person is and how it relates to my salary. And so now I code and manage the complexity of my patients, and it's completely irrelevant to how many patients I see a day, how much I get paid, and it is very freeing. It is also very much in alignment with just taking good care of patients. That's what it feels like to me, is just like I am able to do the best job I can to take care of really complex patients and not have to worry about this other piece of things. So I don't know if that helps you guys think about like, what does it feel like to work in one system versus another?
Yeah, I have to kind of echo Cheryl's sentiment personally, because I've lived both worlds as well. I will say there are some internists who are like super procedural based and maybe less relational based. They love to do lots of injections. They love to do lots of biopsies. And they like a fast pace of doing a lot of stuff. I more love to build trust and talk and problem solve and collaborate. And so, you know, because that's what fills me up, having more time with every patient and not being beholden to producing a certain number of RVUs is in alignment with what I consider good medicine as well. So, but that's, you know, everybody has to identify that for themselves.
Yeah, and I, like Emily talked about, when I was back east before coming out here, I was more on a productivity thing, and it would, right, like our base salary would be like, I think it was like 80 or 85% of what we did the previous year, and then you get the extra based on whatever you're bringing in at that time. And I mean, the benefit for some people is like my clinical director, he would sometimes see 30, 40 people a day and everything. And if he sees that many more people, he gets that much more money. And then, so it's a matter of he can do that. That's what he wanted to do. Here we're salaried, but actually I was in a committee meeting this morning where we're planning a new compensation program where we're giving a little bit more of a little bit bonus for people for mostly more for quality, meaning quality metrics more than a little bit for productivity. But because we also, the other trade-off is sometimes you'll see people who are really slammed and very, very busy, at least as to this full the schedule could be, versus people who are only half full and they get paid the same. And so it's like trying to, not burn out those people who are very, very slammed. And so trying to give them some, even though again, we're salaried, give them some compensation for that extra work so they can get a bonus to be able to do, not feel like they're doing it for nothing to do stuff. So that could be the opposite side, even though again, I'm here. So that's the type of job I want to do, being salaried, but that, there can be that thought to be that opposite side of it, versus fee for service.
I think the question is, why are some of them slammed and some not filling?
Yeah, the other thing I'd say is when I worked in the fee for service model is that you could never sort of change your salary for lack of a better word. And often it can go down, I think for the folks who this year would be a perfect example, the pandemic sort of highlighted sort of some of the payment structure issues in medicine that, people were working hard. We're trying to figure out, how do we take care of patients? How do we serve patients in this current, current scenario? And yet I kind of hear people probably took pay cuts and there was some pretty significant financial suffering that I know about among providers. And I would say in my system, we did ultimately have some small layoffs nationally in our company. But one of the other things that over time, I've been with IORA for 6 years now, is that we have reviews, which I never had. I don't know, other systems may have that, but reviews where you get to learn about how can I improve and get feedback and actually get raises every year. So my salary has gone up over time as well. And, quality and like other things play a role or a part of just your review or assessment. I had never experienced that in 20 years of a review of just getting feedback on how are you doing? Where do you want to grow? How can we help you? That was a pretty new experience at IORA. And I think it's super helpful. I think we all sort of work in these little silos and have no sort of input in that way.
Fantastic. I know that there's another question out there. Other thoughts on this particular issue of fee-for-service, sort of value-based productivity versus value-based care?
I just want to add one other thing too. I think that kind of helps in terms of thinking about the job search is like, even for stuff that is fee for service versus value based, there's a lot of kind of in between as well. And so kind of figuring out what that structure is really helpful. For instance, so we're 90% productivity, but we also get quality bonuses and we get payment for just kind of going to meetings and like keeping track of, the stuff that's going on in PACMed. I kind of think about it in like 3 big buckets, and anyone feel free to chime in if there's kind of a 4th or 5th bucket that I'm missing, but kind of there's the salary model, right, where you're paid a certain amount, and that may fluctuate based on certain things. You may get bonuses, that kind of stuff, but you're paid a certain amount regardless of the patients you're seeing. There's kind of the in-between model where you may have a base salary and then you get more kind of RVU payment and like bonuses, like 50% is base salary, and then you get the extra, based on who you're seeing and more of a productivity. And then there's more of like the productivity based, where it's predominantly productivity. How many patients do you see and how complex are they? And then with some bonuses on top of that. And so kind of thinking about those different payment models can be helpful when you're going into things, because most clinics are still on this fee for service model. I think my hope is that healthcare is moving away from that too, because I think, again, none of us go into primary care because we're like, let's just turn and burn and like see all the people and, get all the stuff done. Maybe some of us do, but most of us don't. And so hopefully things are adjusting for that. And I will kind of a silver lining is that Medicare is actually starting to recognize this and all the between visit care that we do as primary care providers. So they actually changed some of the reimbursement for coding so that you actually get more money for spending more time with patients. There's more of an emphasis on kind of time based. And again, we don't want there to be perverse incentives, things like that, like trying to stretch that, but just recognizing that you get more time, the more time you spend with the patient, and even that between visit care, like you can actually bill for that. So if you're spending 45 minutes, 20 minutes in the room with the patient, but 20 minutes trying to coordinate with a specialist, get them the care they need, gone is that it needs to be face-to-face. If you're still taking care of the patient, they still recognize that for payment. So hopefully we're moving in that direction. We're certainly not there yet. We've got a long way to go, but there's been some changes that are kind of taking the focus on just the like, do the procedures, get it all done.
Thank you. Anisha, can I come to you next for a question?
Sure, yeah. So most of us have experience working in primary care in an academic medical center, and that makes coordinating specialty care much easier because we're working within the same system that we do our residency and our primary care. So can you speak to how you coordinate specialists for your patients outside of your healthcare system?
Great question. Let's see, I might ask, Emily, you shared with, Leslie, you shared with us a little bit that you coordinate with Swedish. I might start with like Doug and Cheryl, just because those are 2 different models, and then back to the others if we have time.
Mostly around here in Edmonds, for example, there's a lot of Swedish. Swedish Edmonds is right here, and then also Providence further up for our Everett locations. And or specialists at Everett Clinic or the other ones in the area here. I do have access to like their electronic records, so I can look at any of the stuff that's involved in there, you know, gets access to do that. And like Sheila said, yeah, definitely a lot of the Swedish patients do see our Medicaid patients very willingly. And that's where a lot of times we get a lot of our x-rays done there, stuff with that. And it works, like I said, pretty well to coordinate with those. It's not quite as, yes, it's not quite as close as when you're directly, you know, talking to them regularly and stuff, but you know, pre-pandemic times would sometimes get a chance to try to go to lunch with some of the specialists in there to try to know them a little bit, at least to try to do this type of stuff. But like I said, I do have access at least to look at all this stuff to be able and to try to send messages to them within their message and stuff.
And just to follow up on that, Doug, knowing what the residents are accustomed to in terms of like placing referrals in our system, are you referring to a specific provider that you have a relationship with? Are you referring to the clinic? How do you choose between like an array of Swedish providers?
Totally. Yeah. Well, and in private practice, I did sometimes there were certain ones that we did. In reality, for this, I mean, you know, it's more a matter of I put the referral, and our referral coordinators know in general what ones we sort of like, but look and see which ones work the different insurance networks. I mean, you know, is the reality of it with Medicaid. But because there are 5 different Medicaid plans, and some of them see different ones, and you know, or stuff with that in reality happens. So that's we sort of it's matter of practicality with Medicaid in reality. But like, for example, there's been a big problem where like one of our plans with United, they have basically there's no dermatology in Snohomish County basically to be able to see on any of the plans. And so we ended up getting coordinated with a virtual, even pre-COVID, but a virtual, you know, dermatology thing. So we can take the pictures here, type in a history and everything, and have all them seen with a dermatologist. And then if there's something really need to be seen in person, still get set up with like UW or down at Harborview. But yeah, in general, it's just putting in a referral. And if there is someone that the patient specifically says, or I know for a specific thing that I want to, then I'll type that into the field in our record for referrals. But in general, allowing referrals to figure out who they can see.
Thanks so much, Doug. And for the residents, feel free to follow up questions if you have follow up questions, or put things in the chat.
I have a separate question, if that's okay. I was just wondering for, is that okay if I ask a question?
Can I time you out and just, can I just go to Cheryl to answer Anisha's question next, just because again, it's a separate model. I think it'd be helpful to talk about referrals, and then we'll come to you, Anna. Thanks so much.
Yeah, thanks. So, you know, each clinic kind of locally has their sort of network of folks, I would say, that they utilize. So, you know, the clinics down south utilize some different systems than we use up north at Shoreline. So, you know, I think some of it is local. And, you know, it is a little bit more challenging, I would say, as far as, you know, electronic medical records. We have our own homegrown medical record that does not directly coordinate. So we're not, you know, getting into it's time consuming to get access and to get into those other medical records. Our health coaches are the ones who do the referrals, and we have sort of a lot of processes around just them getting the records and us being able to have access to them. We also, I would say, utilize, because we have a bit more flexibility in time in our schedule, you know, trying to keep as much primary care within our walls. And so what does that mean and look like? I think it is being able to be more of a learning mindset. So trying stuff as a primary care doc where if you don't have enough time because you're rushing to see the next person, you may not try something or research something and try it with somebody. We also use something called Rubicon, which is an electronic it's a consultative service. So we can consult, if we have a question, we can consult, you know, 2 or 3 specialists and sort of learn how to manage stuff and sort of build our own skills in managing things. So I think there's sort of several different ways that we manage the need for specialty referrals.
Thanks so much, Cheryl. There's been a request. Wendy, would you mind weighing in as well on referrals within the correction system? And then Anna, I'm going to come to you next for your question.
Sure. So it's a little different in corrections that basically we get our patient population is guaranteed. So you don't have to build your own patient population, but they come from all over the state. And many of them are coming in with an existing specialist. So, when we're doing referrals out to a cardiologist, if they are already connected, obviously we want them to have that continuity of care with their main provider. And so sometimes a patient may, we coordinate with our custody partners, but the patient may be, housed in Monroe, but seeing a provider over in Spokane. And we just arrange for their transportation so they can have that appointment and then come back. So it's a little bit more complex than maybe some of the others, in that you are dealing with specialists around the state. It does give you the opportunity to connect with lots of different providers when you're doing those referrals, and really get a sense of community for everyone in Washington state. But it is a little bit more of a challenge. We have patient services reps that help kind of actually set up the meeting and coordinate the custody that will be accompanying the patient if they're going off site. But much like, I think it was Cheryl who said they try to keep as much as they can in-house. And that's definitely, what we try to do with procedures and things. So we have a credentialing committee, and if you want to do certain procedures, we make sure that you're credentialed to do that. We have in-house databases and up to date. So we encourage our providers to do some research. We see a lot of really unusual things come into prisons and some very complex issues. So they're often in that database kind of looking at, they take a picture of the skin condition and they're looking it up. What the heck is this? So we do have some really complicated cases, and obviously some outside referrals need to happen. But we also have some great relationships with the local hospitals and with the specialists. We have a lot of specialists that will actually come in and do services in-house. And so that helps. We have a dialysis clinic that is an outside provider who comes in and does the dialysis for our patients. So there's a lot of ways that we work around the confinement of our patients, which is also another consideration for us.
Thanks so much, Wendy. I'm getting a note that we're going to close the room soon. So I want Anna to ask her question.
Just quickly, how much weekend and after hour call do you expect your physicians to take in their practice?
Great question. Leslie. Cheryl, someone.
We take call
This
basically.
is Sheila. Oh, sorry.
1 week, probably every 8 to 10 weeks. And I was just on call. I probably got a total of 10 calls in the full week. It's very manageable.
Sheila?
Hi. So same. Our providers rotate call. It's phone call only. We have a hospitalist team or nurse triage group that will take the first call. So their physicians are only called if they can't figure it out. And it's usually one weekend every 8 to 10 weeks. And then they take their own call sometimes during the week, but it's very clinic dependent as well. But I would say call for primary care, at least within like PacMed, Swedish, Providence, is very minimal. They never go in.
We share call between our internist group. There's 7 of us, so we rotate call. We're usually on call during the weekdays for about like once or twice a month. And then we also have a weekend call every like 1 or 2 months. It's all telephone. We never go in for call too. We don't have a nurse triage though. We're doing all that. So it's another kind of important question to ask, is whether you've got a nurse triage when you're taking call.
We have 1 week every quarter to every 5-6 months that we take. Same with the others. We have a nurse triage. We get very few calls in a week's time. Phone only, never go in. It's easy.
Similarly here.
3 seconds. All right. You are consenting to be recorded. Sounds so formal. Let's continue. All right. Well, thanks to you primary care folks that I didn't get to see on my side of the panel. It's great to see familiar faces. Did everything go okay over there? That's awesome.
Great. I just want to acknowledge, Jennifer, that we were deep in conversation when we got cut off. So thank you so much to all our panelists and for our engaged residents.
Yeah. Yeah, we filled our time
Thanks for
as
having
well.
us.
Thanks for
Sorry I was
coming.
on mute the whole time.
Everyone.
Bye-bye. All right, well, we'll let our panelists move on to the rest of their day. And again, we'll distribute their information, all the information for both primary care and hospital medicine to everybody. And so I think we just want to end with just a little bit of talking about kind of general job search strategies. We did have a comment in our, or question, I will say, in the hospital medicine group about, you know, what should we be looking for in a contract and contract negotiation? And that's a really big topic that is covered in kind of the Life After Residency and Fellowship seminar that will happen this fall. And that's something that's offered virtually and recorded and will also be distributed to you. But we didn't spend a lot of time in our group about that because it's just its own kind of big beefy thing. And we actually bring in a contract lawyer to talk about that. So that's certainly something that I think most of us felt really uncomfortable with when we first came out of training, because it's, you know, just kind of a new world that we haven't navigated. So I'm going to share my screen here. And we'll just talk for a minute about maybe some general things to keep in mind as you approach this job search, regardless of what side you are considering. You can see that. Trying to advance my slides here. It always takes a minute for the first one. There we go. Okay, so I'm going to just plow through this because we're going to be done at 2:50. So I think the first advice is, first pitfall, I guess, would be waiting too long to begin. And I think what we heard, at least on the hospital medicine side today, was that, you know, people are pretty much looking at hiring kind of in the middle of the fall. And so as a program, we have taken the stance that, you know, starting kind of in July and August, you should be thinking about assembling your application materials. And we'll talk about those in a minute. Those can take some time to kind of put together. So I think nobody wants to be really caught out. And so one thing you can avoid is waiting too long to begin the process, with the focus of trying to have everything in place by the end of August. Second one would be going it alone. You know, there are job opportunities that come in, you know, super frequently to the program, to Ken, to us. We share those pretty liberally with you, and we'll continue to do that, but leverage your networks, ask around. There are so many people who can connect you, and most residents, when you ask them, have obtained jobs through their personal networks. And so those might have been med school or residency or their faculty networks. And so please don't feel like you need to find these jobs on your own. There are lots of folks that can help you, and we will be proactively sharing information as we get it. Great topic for your program mentors as well. The third pitfall would be procrastinating on creating your application materials. And so again, Ken talked with you, I think it was October, November, about kind of how to create a good cover letter and a CV. The CV is obviously kind of a chronological accounting of your accomplishments, your experience. We'll distribute the UW School of Medicine format. And that, people sometimes ask, like, should I do a different CV for, you know, non-academic jobs? And I think that even the non-academic jobs are pretty accustomed to seeing formats in that general, that look very similar to the UW format. So I think that's a great place to start. Your cover letter should not talk specifically about what you love or what you want, but really what you offer to the group. And so I think really understanding kind of their core mission and their core needs and speaking to those in the cover letter will make you the most kind of powerful and compelling applicant. This is a thing where you might also want to spend some time getting feedback from folks in your life who you trust. Again, program mentors, other faculty, friends, having people take a look at those to make sure that they really reflect, I guess I will say, your best self. Sometimes we have a difficult time writing about ourselves and really kind of playing to our strengths, and other people can kind of encourage us to kind of pull some of those more superlative details out in our letters. So don't wait too long to do your CV and your cover letter. Number 4 would be neglecting your social media or online presence. I think it's just a reality now that's important to mention that employers do investigate, you know, potential hires online. And so I think if you haven't already thought about this in residency, it's a pretty fair time to take stock of what's out there on the internet about you and what might people see, right? Some folks choose to be proactive and create a LinkedIn presence where they actually lay out their professional desires and experience. So that's something you could think about, but you obviously want to be mindful of privacy settings, the photos that might be posted, any sort of, discriminatory or inflammatory or, overly overshares that you might have out there that people might come across. And then just also be aware that as you're going through the process and you might name names of potential employers if you're posting about something, that employees may also have alerts set up that would cue them to something that you may have written about that. So I think kind of keep it polished and professional and just kind of take stock of what folks might have access to if they go to look your name up online. This was brought home really painfully to me by somebody who I went to a conference and they reminded us to do a Google audit. You should always type your name in and see what happens. It turns out that when you type in Jennifer Best, that there's a porn star named Jennifer Best. And so the first post was this Jennifer Best and not me. And so somebody suggested that if I wanted to manage my image, I could buy the URL, but no thanks. But anyway, that's kind of my funny anecdote. Number 5, don't ignore publicly available information. So this might be things about, again, what is their mission? Do they have financial challenges right now? Are they in the middle of leadership transitions? Are there key initiatives, centers, things that you actually can enhance that they're already doing? And speaking to those in your cover letter. So I think doing due diligence kind of beyond the basics really serves your interests well when you're looking to distinguish yourself as a candidate. And there's a lot of things you can find out online, right? Salaries, also state salaries, just the salary, but those are publicly reportable. So there's lots of stuff online, and be prepared and do your homework. Number 6 would be, don't ever assume it's a done deal. Even if somebody says it's a done deal, wait for things in writing. Comport yourself as if you are one of many applicants. I have seen folks from inside the program come to interviews just kind of dressed shabbily or dressed in scrubs, kind of assuming that, I'm from here, people know me, but it's a job interview. So kind of put your best self on, regardless of how familiar the environment or how familiar the folks. Always get things in writing. Number 7, I call hoping they won't notice it. The it might be, I was a primary care resident, now I'm going to be a hospitalist. Have an explanation for that. Be able to discuss your process. Maybe you had a gap in training or took some leave. Things that might be obvious if you lay out a chronology. Proactively, have thought about how to kind of address those in an interview should they come up, and be able to own those in a way that feels like it has agency. Number 8 would be failing to connect with your references in advance. Usually the references that you provide for these jobs are not letters in the typical way that they are for fellowship applications, for example. Often it's just names and emails or phone numbers, and sometimes they're electronic forms. And so tell those people that you're using them as references so they're not surprised. And if there's a particular thing that you would like them to highlight for a particular job, that's also a really nice thing to call out for them in a way that can, again, just be a little distinguisher for you. But references should never be surprised that they have been listed. So that's an easy pitfall to avoid. Number 9 would be saying yes too quickly. Again, we just talked about the fact that you guys are highly sought after. So this comes in like 2 flavors. And the first would be saying yes to the first job offer that you get, kind of hoping, worried that